Hey everybody, Dr. Rayner and Dr. Nutt here with another episode, and we're going to go and dive into the pathways behind perceiving pain. I'm going to be interviewing Dr. Nutt and kind of having some back and forth discussing what happens when people perceive pain and what happens when we get into these chronic pain states. So let's take it off.
Yeah.
So how often do you see chronic pain? And just before we go into the meat and potatoes of it, how often do you see that impacting patients in our clinic?
Every day. Obviously, the majority of people who come into the office have something going on that hasn't been treated well with typical, your typical type of healthcare. Medication is one way. Physical therapy, chiropractic adjustments, massage therapy. Usually we're being referred to these types of patients from providers who provide those types of therapies and aren't seeing the results. And when we get these types of patients, we have to think a little bit outside the box. And we have to really break down the neurophysiology and how the brain is connected to the body and how the body connects to the brain, and how we are how we can give certain therapies or different layers of therapies at different, kind of taking different angles to inhibit that pain response.
Are we as humans or as mammals, are we designed to perceive pain for long periods of time?
No, I think we are designed to perceive pain when necessary, when we have to change our environment or change our situation. Pain should be fairly transient. It should be, I'm feeling some type of pain. I did something wrong. I slipped. I twisted my ankle, and now I have pain. That pain response. Everyone thinks of pain as a bad thing, but we should be looking at it as a good thing. When done appropriately, pain should be saying, "Hey, you rolled your ankle. Let's lay off of it for a little bit. Let's try to stabilize. Those muscles are going to go into a guarding technique, a splinting technique that makes the muscles that cross that joint very tight and very tender, and basically it's a signal to your brain saying, hey, this area is injured. We got to lay off of it, and we can't sit here and have go walking around on it. Pain is there to tell us that something's broken.
Yeah, an alarm system.
Exactly.
Right? It's an alarm to acknowledge to our consciousness that something happened, and we should probably either heed, adjust our behavior, or seek help.
Yeah,
right.
Get somebody to help.
All right. So I think looking at when pain is a good response versus pain as a chronic response, let's go through how does pain get from our out in the periphery up to our perception.
So when we're sitting here, our socks, this watch, my shirt, my clothes, and sitting on my butt on this chair right now, they're all stimulating the pain response. But there's pathways in our periphery, there's pathways in the central nervous system, which is your spinal cord and your brain, to help inhibit those signals so that I only feel the pressure of my butt sitting on the chair or the pressure of my socks on my feet.
So is pressure different than pain?
Yeah, because it's stimulating a bigger receptor. So there's a whole bunch of different receptors. There's nociception receptors. Nociception is a fancy word for pain. Then there's unpleasant stimuli. Pain can be termed either hot and cold, or it could be an actual painful response. Something like a penetrating pain, like a sliver, like if you get
those are the worst.
Yeah.
As I pulled a few out of my hands yesterday.
Yeah, if you get a splinter or something, or if you have a pinprick, or if you touch a hot stove, or if you bonk your head on something. I always use the bonk your head response because everyone bonks their head, and I like to use the metaphor of when you bonk your head, you don't just sit there and go ow, that hurts. You rub it.
You
immediately grab it and rub it. If you stub your toe on the coffee table, you grab your toe and you bounce around and you pull it, or you grip it, or you even if you have a toothache or something, you clench your jaw and it temporarily inhibits the pain. There's lots of different ways that you see this naturally, and we have these natural responses for pain inhibition, and all of that pain inhibition is because the pain fibers. There's two main types of pain fibers. There's delta fibers, which are your quick, fast pain, And then there's C fibers. C fibers are easy to remember because they're more for like chronic pain. And when we have these types of painful responses, all that pain, and those little fibers, those delta and C fibers, they're really thin, almost unmyelinated or very thinly myelinated. Myelination is like the rubber coating on an electrical cord. So if like my phone charger has, missing the rubber on the phone charger, I plug it in, it might charge, but it might not charge quickly. It might not, it might not work in certain positions. So if you don't have that rubber coating, you lose the ability to transmit signal. And these pain fibers, the good thing about them is they're very thinly or not at all myelinated, which means the signal is very weak. And that is a really good thing because we can inhibit that response even easier or better when we excite these big, thick, myelinated nerves. Now, those big, thick myelinated
What do they
nerves,
carry? Like,
those carry movement, touch, vibration, pressure in a good way. Like if you bonk your funny bone, you grab it and you rub it and you do like a deep rub or a deep massage.
So pleasant
responses,
yeah.
Exactly. Maybe even like like if your low back is just kind of like chronically painful, like you have that like deep, not really specific to one spot, but it's just kind of like deep and achy. This is why massages feel good.
Or the vibration
feels great. You can really inhibit these pain fibers. And the nice thing is how we're wired is those pain responses go into your spinal cord. These big, thick myelinated nerves go into the spinal cord, and they give off these little branches, these little like interneurons, basically a communication from one neuron to another, where there's an inhibitory response where the big, thick nerves, they say, hey, my information is more important. I'm going to signal over and inhibit the painful response because my information about movement is more important. So basically it'll inhibit the pain response right at the spinal cord, so it never even gets to your brain.
So that's why when I hit my thumb the other day with the hammer, you shake it,
you
do motion or pleasant or pressure.
Yep.
And it gates the pain from getting
exactly.
to
Yeah. Exactly.
Okay, so from a receptor to the spinal cord, where does pain go? Let's say pain doesn't get inhibited by motion or pleasant stimuli, gets to the spinal cord, where does it go from there?
So it goes up a pathway called the spinothalamic pathway, and it's a really important pathway because this is where pain, if it's a chronic pain, that chronic pain, and we always talk about neuroplasticity. Neuroplasticity is the concept of the more you do something, the more efficient you become, right? So if you have, let's say you have fibromyalgia, or if you have like a high school football injury in your knee, that's just a chronic injury, that spinothalamic pathway can actually become what we would call negatively plastic. Negatively plastic would be essentially saying like you're becoming more efficient at something that we don't want.
Yeah,
more painful, more perception of pain.
This is kind of off topic too, but when you get into injuries like an ankle strain, like do you brace it or do you not brace it? Because if you allow them to perceive ache and pain but lose some motion, it just plays into it.
Yeah. Oh yeah, exactly. Like this is where, and that they're depending on the severity of the injury. Obviously, if you have like our massage therapist Al's injury, complete tibial and fibular and dislocation, that type of fracture.
Stabilize that one.
You're not going to rock tape that one.
No.
Right?
You got to stabilize that one. That one's a bit warranted. So ideally, if it's a stable injury and there's no risk outside of you being a dummy and using it too much, causing more kind of inflammation to migrate, which will play into pain as well. But if it's a stable injury, allowing some loading of gravity or motion would be advised from a pain standpoint long term.
Exactly, and I think when it goes up that spinothalamic pathway, it goes to areas of our brain that help us perceive pain, and one of the issues with that is once it gets into the central nervous system, the areas of the brain that perceive pain will drive a protection response, but it also gives us chronic pain can also kind of lead into the same pathways that perceive pain can actually lead us into like an anguish pathway as well. So you actually start becoming anxious or even depressed because of pain, right? And everyone that's had, a rolled ankle, it's just miserable, right?
Yeah.
Or a shoulder injury or an elbow injury or whatever joint or whatever muscle or whatever tendon or ligament or whatever back pain and neck pain. I mean, the number one reason for people to miss work is back pain in the United States. Probably because we sit on chairs all day long, we don't move, and we look at a laptop. And especially over COVID, one of the things that I notice is like people going from the office to working at home. Well, I can't tell you how many people came in going, I'm sitting at a laptop. Yeah, I'm sitting on a bar stool, or I'm sitting using my laptop on the couch. And the laptop is sitting way low on the coffee table, and the laptop's already bad to begin with because it's like you have to hunch and lean forward, and then you sit on a chair that's just like super squishy or too hard or a weird angle, and now we're hunching forward like we're some sort of like Igor, sitting at a desk for 8 hours, 8 hours a day. And then we're sitting on our phones at night, and it's like, oh my goodness, this posture. So those chronic fibers that fire up, well, offsetting that, the vast majority of our brain matter, about 90% of our neurons in our brain are there to help us perceive movement and help us perceive the environment. So if we're not perceiving the environment appropriately because we're not stimulating those neurons, I mean, you're gonna have an like
phantom limb.
Yeah, exactly.
Somebody loses an arm, and let's say the region for where that arm is represented in the opposite side cortex, it doesn't disappear. I mean, it's still present, and so your cortex over time can have kind of like an invasion of that map of what used to be arm, and so you can have misrepresented touch, pain. You can have other regions of the brain kind of like hack into it. And it can be a mess from a pain perception standpoint.
Absolutely.
I mean, what's one constant that's always a good sensory on our system? And I mean, that's where we talk about patience, is gravity.
Yeah.
And so just getting up and opposing gravity in different planes and moving is just one of these things that we should be doing every day, just on a very basic fundamental pain standpoint. And so when you talk about pain and plasticity, it's kind of like you use it or you lose it. And I think that's the big thing. If you use it, you're going to reinforce it. Now that works against us when you just talked about like chronic pain. Mm-hmm. If you're having this perception of pain, you can start to have plasticity in that pathway. So now we got pain up to perception. Now we don't want that to be chronic. What are the systems that our brain has in place to go back down the spinal cord and shut pain up, or kind of help modulate it over time?
Absolutely.
Or is it just once it gets there, it's got to be there for a period of time? Like how do we start blocking pain?
So we have an area of our brain called our Raphe magnus, which is basically like your Raphe nucleus, and your Raphe nucleus is a really important part of our brain that helps produce serotonin. And that serotonin, a lot of people think serotonin, that's something that keeps me feeling happy or not anxious, or but the interesting thing is that serotonin that our central nervous system produces, the vast majority of it actually goes down our spinal cord to inhibit pain.
Yeah.
So it's not made for happiness or something like that. It's actually there for pain inhibition. There's also other areas. The periaqueductal gray area is really important for inhibition of pain. There's a couple other spots, but the main thing is that pain inhibition coming down the spinal cord. This is why, like, someone who has depression is treated with the exact same medication, an SSRI medication class of medications. SSRI, selective serotonin reuptake inhibitors, are used for people with depression, anxiety, but also for fibromyalgia or chronic pain symptoms, chronic fatigue
Trying
symptoms.
to modulate the central aspect.
Exactly. Yeah.
What about the whole opioid crisis? Because that's a whole crap show in
Yeah.
itself, right? I mean, it's one of those things where, how many people die per day due to opioid overdose, which is just disheartening. But from a pain standpoint, we produce our own opioids.
We should be producing our own. And here's the interesting thing about that is if we are, if you're serotonin deficient, you could perceive pain more, but you're also going to have problems with falling asleep and staying asleep, because when the sun goes down and we stop activating the receptors in the back of our eye. I shouldn't say when the sun goes down, because most people are on their phone or watching TV,
and they're inside. They're not
seeing
the sun.
They're not seeing the sun go down. But when we stop activating the receptors in the back of our eyes for light with light, we should start having a conversion from serotonin to melatonin. And when we fall asleep and stay asleep, well, between 1 a.m. and 5 a.m. is when we produce the vast majority of our endogenous opioids, basically these things called endorphins, that'll help us inhibit pain the next day, gut function. This is like a lot of people have heard of like low-dose naltrexone, which is a medical treatment for people with autoimmunities and chronic pain and those types of things. It's a pretty cool idea, inhibiting opioid receptors for a very short period of time, and then our brain will have a huge increase, about 50 times the production of internal opiates. The problem with that is that's only true if we get deep restful sleep, kind of like our most restful sleep. So this is why a lot of people, when they feel pain, they're not going to sleep well, and when you don't sleep well, you perceive pain more. So it's kind of a
throwing depression to that bag mix. Like if you're depressed and you have an injury like that may be nominal, like not a very big injury, are you at risk for chronic pain morphing out of that, or are you at risk for fibromyalgia?
Absolutely.
Or vice versa.
Yeah,
they like to go in tandems.
This is like the perfect storm. This is where things can really spiral out of control. Is like a little bit of sleep problems can turn into chronic pain and depression and fatigue and helplessness and hopelessness.
I mean, during the sleep cycle too, other podcasts, or I can't remember if it was a podcast or other videos I've been doing, growth hormone peaks during your deep sleep as well. So this is where like sleep's such a critical time. And I think there's times where people sometimes joke about how bad, like, I just need 4 hours. It's like,
I'm a 4-hour person, or like, I'm a night owl. And it's like, what is that really telling us about our physiology?
You're a night owl, but what's it opening you up to long term? Because again, we should have this pattern of behavior where we kind of go down with the sun and rise with the sunrise. And I think, you can be a night owl, but does it mean it's adaptive for the long term? In terms of, other things we recommended on previous podcasts in pain, and we're just like the uncomfortable feeling when you're in a sauna. I think that's the other thing too, is pain, and it's that dynorphin response when you're getting in the sauna or just feeling unpleasant things like pushing yourself. Those things help you recalibrate your own opioid system, your mu receptors, so you're more responsive to your opioids. So there's so many aspects to it, I think, that we can tap into. So we're now kind of morphing through central pain back down the spinal cord, modulating it through your serotonin, your opioid system. What other things, kind of while we're still up at the central processor, the computer, the brain, can play into our brain? So let's say somebody is has already depression. We talked on that a little bit with the ties to serotonin. What if somebody's just got frontal lobe health issues or anxiety? Does that have an impact on pain?
Absolutely. I think when you tie anxiety and from a frontal lobe perspective, if we lose frontal lobe is for your cognition, it's what makes you, right? It's what keeps you from acting like a selfish animal, right? Like it's keeps you from it's what allows you to share your food. It allows it allows you to do math and see into the future, and allows you to plan ahead, and I'm making noises with my mouth and you're perceiving them, and they actually mean something to you. You can look at my face and see emotion. I can look at your face and see emotion and perceive that emotion without saying a single word too. So your frontal lobe is who you are. And when we lose that frontal lobe, you can see people not just with depression. A lot of people think depression is the word depression to me doesn't mean like this person has emotional problems. The word depression to me means this person's brain has depressed neurological activation.
Yeah, the way I describe it is, let's say this is where you thrive at and this is your optimal baseline. Depression is you firing below that rate.
Exactly.
That's the way. And so anything can come in. It's not just serotonin. It can be thyroid. It can be inflammatory. Can take you from that peak dopamine. It can take you from that peak threshold. It can be vascular, like you're not getting fuel, you're not getting oxygen, but taking you from a peak threshold and dropping you to a suboptimal level. That's you're functioning at a depressed level, right? This is your normal. And so, you pump in some caffeine and you're trying to elevate you above that level or get you back to that level. And again, it's just, I think depression has a stigma to it. And I think it's just, we need to kind of move away from that and just like, no, you're just not at where you should be at. Whether it's
the emotional aspect of depression is a symptom of your brain not firing as it should be. It's not getting enough activation.
Yeah.
And that's why, it's crazy because how many college kids and high school kids are and people who work kind of like high stress jobs, it's like, what are they all taking? Adderall, these stimulants, right? It's like, and we pump those for years and years and years, and your dopaminergic pathways, the things that give you reward and motivation and drive, the things that get you up in the morning to be excited to go do what you do what you love, all that stuff becomes altered. And when we have these depressive states, we can move away from it if we change our mindset on depression, because depression is not emotional problems. Depression is a poor activation of brain. So, and we know that to be the case because look at the research. I mean, since the 70s basically has always said the best treatment for depression is exercise. Nothing touches it. SSRIs, SNRIs, Wellbutrins, all those medications, you can't get artificial movement.
So, and then again, when you picture from a very global, and then even tying this back to pain, like now we're kind of gone down the mood aspect. But let's come back to pain. Like, if you can move, what's your chance of gating and controlling pain? Like that's you're engaging parts of your brain that activate all your good areas of your brain in terms of like your cerebellum, the frontal lobe, GABA activation that has a huge modifying response to pain. But yeah, it's one of those things where we move less. You'd said something probably like 2 or 3 minutes ago, talking about kind of anguish and seeing kind of like facial tone and being able to, you don't even have to say something, but you can see if somebody's perceiving pain, which kind of pulled my brain back kind of to a phantom pain, but Dr. Ramachandran and kind of the mirror neurons aspect of our brain and how that can influence. And my thought process was, if you're in pain, and let's just say you are surrounded by other people that aren't lifting you up or having good energy, if you want to call it that, just giving you off bad mojo or vibes, right? I mean, you ever walk into a room and you see somebody just kind of like posture, face sunk, sour, kind of just like you see them like not feeling great, miserable, whether it's blah or in pain. The problem with that is that that's all you see. Your brain's looking for positive influences all around, and this is kind of what the mirror neurons, we have them in our sensory and our motor cortex. And so it's like, well, if you see somebody like stub a toenail, you have like activation in the part of your brain that you didn't perceive it, but yet your brain still heightens up like it did perceive it, and same as your motor cortex. And I think this is where it's something we take for granted in its role of how we feel and how we have pain. It's like, if you have 10 negative people around you and that's all you have, and you're also in a bad spot, I think that's going to give you a very heavy anchor and keep you kind of stuck in that spot. And I think it's just one of those things where when we work with people and we want to look at like, how do we get you out of this? I mean, you need to have people around you giving off what you want to move towards, because again, it's like there's this whole actual mirror neuron aspect to perception and to pain, to pleasant stimuli. So it's just when you were talking about that, I'm like, I mean, it's very easy to get kind of sunken into a negative hole.
Absolutely. I think the mirror neuron thing, it's like, I remember when I was in school learning about this, and the teacher randomly just put a video of a guy skateboarding, and his skateboard wasn't on his feet, and
the pole is
kind of one leg went one way, one leg went the other way, and basically racked himself on the stairs, and every guy in the room goes ooh, and you actually perceive a little bit of that pain when you see somebody else in pain. And what you're saying about having your community of being like positive, there's a whole industry made for people who are mindset coaches and basically motivational speakers, and people who are there to give you energy and kind of give you that ability to like get yourself out of these ruts, and that goes hand in hand with pain, emotional pain and perceived pain of breaking my finger or something like that. They stimulate similar areas in the brain, and we have to have a neurophysiological pathway to inhibit that pain and get ourselves out of that. Mm-hmm. And a lot of times the missing pieces might not be what a lot of people think. Movement is important, stimulates your brain. I think having the emotional and social support is super important, and getting out of our Western world is really important too, right? Getting back to things that are a little bit more primitive.
If you have a toxic environment, and let's say you're 3 years into chronic pain and you're still going to a high stress job that basically prevents you from sleeping and what have you, I just think this is where this conversation has to go sometimes as a provider. Is like, here are these environmental factors that might be holding you back from actually getting through this pain. Mm-hmm. You're coming to the office to have more, is there other things you can be doing, whether it's physical modalities, physical medicine, biochemistry, is kind of, you can overcomplicate it with it, but sometimes it's there's more things right in your direct environment that we have no control over, and it's all on the patient itself. It's like, hey, if your job doesn't allow you sleep and gives you anxiety because it's high pressure and your boss is very volatile, then it's one of those things where like we can't touch that.
Yeah.
But that might be having a role in it as well.
Yeah. Patient might only be here for 30 minutes, an hour for a week, but what are you doing for every other hour? You're here for 1 hour out of the 24 of that day, but what are you doing for the rest of that day? Are you sleeping right? Are you eating inflammatory foods? This is where, from the neurochemistry side of things, it can, you can do the perfect modalities. Providers can do the perfect therapies, but it's not enough to overcome the stress response, the anxiety response that's making us perceive pain a little bit more. That it's not addressing the neurochemistry, the peripheral neurochemistry. Like GAD antibodies is something that we test for. Yeah. And when you see GAD antibodies, GAD, glutamic acid decarboxylase, is an enzyme that converts glutamate, super excitatory neurotransmitter, the same stuff that's like in MSG to make food taste more exciting, like bland Chinese food, like rice and chicken, and then you throw a little bit of MSG in it. It's like, wow, this tastes so good. The flavor enhancing aspect of it is just an excitatory neurotransmitter touching your tongue and stimulating those receptors to perceive taste better. And the interesting thing is, like, look at someone who takes MSG and has chronic pain. What are they feeling more?
Well, glutamate pain is a huge signal through your NMDA receptors to pain in the central nervous system. It's kind of the upper switch per se. We talked about serotonin, our endogenous opioid system, for kind of helping us dampen it back down. But glutamate is going to be one of those signals that come in, and from a very basic premise, just like those GAD antibodies. If somebody's got GAD antibodies, one, they're more susceptible to being like stiff, having poor muscle tone because of the impact to GABA. But GAD is what takes glutamate, converts it to GABA. GABA calms us down. So there's also the anxiety aspect. GABA also is really important for muscle tone. That's unconscious primarily.
Yeah.
So let's say that person has GAD antibodies, so they're not making the enzyme that takes them away from anxiety or enhance pain to calmness. Mm-hmm. They're B6 deficient, which is very, very prevalent. Every time we run those labs on most people, probably like 95% are B6 deficient. B6 is critical for that GAD enzyme to work. And then let's say on the other side, that NMDA receptor also has magnesium lodged at the base of the receptor. And so let's say the magnesium deficient, B6 deficient, GAD antibodies, and they're just in an inflamed state. Like, pain is given this full clear pathway to ramp right up.
Nothing's able to inhibit it because you can't produce the the chemical compounds to inhibit it.
Well, and from magnesium works from forming a plug at the base of the receptor, and so glutamate wants to dislodge the magnesium so you can have calcium flood in and sense the activity or the excitation of whatever it's trying to trigger if it's pain. So being magnesium deficient is another way. It just makes it easier for you to have an improper response to pain. And so this is a whole other aspect. Like, I'm not sure if we want to go into it right now, but like the chemistry side of it, I think it's not a bad thing. I think we can touch on it really briefly. But like, sitting there, and if I was to take and whack your forearm, it wasn't painful. And let's say I whacked it hard enough where you had a short pain response, but then all of a sudden a bunch of inflammation migrated and it formed a bruise. That bruise is going to be sore for a period of time. And so that's normal pain signaling, right? And so now when you touch the skin when there's a bruise or trauma, instead of light touch or like, oh, I feel the hair standing up, you'd feel somebody like rubbing a bruise, like, oh, that's kind of achy and allodenic or painful. So from an inflammatory standpoint, what happens when a bruise occurs that takes that pain fiber that should be harder to excite than motion? Like, why am I, when this should be perceived as touch, what does the bruising change in terms of the nerve fiber?
Well, it'll sensitize the nerve fiber because of like we were talking about with if there's tissue damage, it's releasing these inflammatory cell signalers, cytokines, interleukins, and basically when there's a whole bunch of other systemic things that'll kind of help us keep that inflammatory state to a minimum, right? Keep it local. And this is like, if you want to talk about like diagnoses, like RSD, regional sympathetic pain, or Sudex atrophy, like a whole bunch of different types of terms for the same thing, these autonomic control problems, inability to regulate things automatically appropriately. So now we have like expansion of that nerve pain. So it's like nerve pain that goes from the wrist, and this is typical after like injury, like for instance, I have a patient, she broke her wrist, and now she has like really sweaty, clammy hand, like an overreactive sympathetic local. Sympathetic.
So you're going on the autonomic, like, okay.
Yeah, that autonomic aspect of things, basically the inability to inhibit that pain response, but also you see like a sympathetic change, blood flow problems. But if you were having a normal response, that bruise would stay local, and that bruise, that inflammatory response, would basically be a signal to the brain saying like, ooh, I have an injury here, let's send some excess blood flow, or let's change the way that we're gonna, basically there's inflammation here, let's go there and fix what the problem is in a normal response. But a lot of people, when they're already in this kind of fight or flight response or inflamed systemic inflammation, you can see changes where we don't have an appropriate response anymore. Now we have an inappropriate, overabundant fight or flight reaction, that sympathetic tone where you see changes in blood flow.
Well, and that's where it's like the resting biochemistry, the neurophysiology of pain versus motion, right? I mean, there's a reason why light touch should always perceive touch over pain, right? I mean, that resting potential is closer to excitement, right? So it's like why a tap versus a punch give you, you're still hitting the same region on the skin, right? It's just why will one trigger pain versus one trigger touch? It's the intensity of the signal,
stimulus, yeah.
Right? And so pain has a lower, it rests further away from threshold, which means it's going to take more to excite it. That's where I think, probably the hardest and most mismanaged aspect of pain. Well, central pain's a whole other bag of apples when it gets plastic, but inflammation takes that resting potential and gets it closer to being on par with threshold.
Yeah.
Right? And so now when you move, or the wind blows across your shoulders, it's pain, it's achiness, it's you're the fibromyalgia type of patient as well. And I think that's where, when you look at histamine omega ratios like arachidonic acid, so your people that vilify it, you need it from an inflammatory response, but when you have poor omega-3s, you can't kind of dampen that omega-6 or the arachidonic acid pathway. Histamine will increase pain perception. It can be something like your GI pain is a lot of times histamine related, or headache and migraine pain can be histamine related, but it also has a role in the peripheral. Lactic acid, oxygen deprivation, when you work out and you start getting less oxygen to tissue, you kind of get more waste accumulation, and now your muscles are sore the following day, telling you not to use them as a warning or alarm. But again, showing how something acidic or inflammatory takes you closer to an excitation. We had this conversation, and I was, before we're prepping for this podcast, I had a call with a patient out in California, and just kind of talking, and kind of brought up about there's I think it's Dr. Tennant, who has this whole philosophy, like we're all different electrical charges, and she's like, oh, it may sound crazy. I'm like, you know what? No, it doesn't. Because we are really that, and a lot of the premise of how they go after things is trying to reset your voltage, your how polar you are. And it's like, well, why do we go and say, hey, you should drink alkaline water? Right? It's more negative. It's acidic is more positive, alkaline is more negative. And so you start thinking about this, you're like, and you start kind of going through, like, lactic acid is more acidic, arachidonic acid, and you start kind of going through, and that's why I was like, I didn't poop on it. I'm like, no, it makes, like, I'm kind of stepping back, and I think that's the one thing we always try to do is, like, if you don't understand it, try to understand it, and kind of just going through the whole aspect of, like, grounding, putting your feet on the soil. Like, that's we were sitting there yesterday, like, hanging out, drinking coffee yesterday morning. We're like, why are we sitting outside with, like, our feet not on the grass? And it just feels good. But the earth has this negative charge, and that's the whole premise on grounding, that it helps reintroduce or renormalize your natural, like, negative resting rate. And again, it just kind of made sense from a pain standpoint, because the more negatively set your pain threshold is, it's the harder to excite. So it's just this, I just don't think we really fully understand, and in every profession, the whole aspect of how,
oh my gosh,
tied to earth we should be, and how disconnected we've become.
It's one of those things where we see it all the time, where someone's in pain, they go to the beach, and it's like, how healing they are, sitting on the beach with your toes in the sand, or getting in the water and swimming around. It's like there's so much healing aspect to that. It's not just like I'm getting away and I'm living stress free, but it's also, you're just reconnecting with nature and getting your feet in the sand, or getting your feet in the ocean and swimming in the ocean. There is a healing aspect to it. Now, good luck getting insurance to pay for that. I always tell people, if we wanted a really good health insurance program, it would be great if we could have a
covered vacations
1 week, every 6 months in Mexico, or on the beach somewhere.
Can be the mountains.
Could be the mountains. And everyone has a different, and you're drawn to those things maybe because of what we're needing. So I think that it sounds very, and you and I are very science-based, very evidence-based, very, like, where's the research? But you don't need research to tell you that when you go to the beach and you recover calm, and you feel calm, and your pain is getting better. When there's enough case studies where people go somewhere and get a chance to unload, and when I say unload, I mean maybe unloading some electrons back into the earth and kind of getting back to a more resting state.
It's just one of those things where that conversation, my mind was like, man, I could go deep on this, and kind of looked at every little implication of it, and you're like, okay, even on an anxiety standpoint, like, if you're easier to provoke and have, like, a perceived, like, ramp up, again, like, is there an aspect of, like, just basic electricity, right? I mean, is it easier for the electron or the electrical signal to overexcite a pathway and give you anxiety? And again, it just was a whole rabbit hole where I'm like, hey, look, I get it, I don't understand it, but I think there's something to it, because just when we look at basic neurophysiology, there's the more positive you get, or closer you get, the easier it is to excite pain.
Exactly. I always use the kind of metaphor, like, if someone is bugging you get closer and closer to threshold, right? Like, I've had it up to here, like, tap. One more thing, one more negative comment, one more nagging thing, and I'm just gonna lose it. And it's like, that's every neuron in your body isn't doing the same thing. Are we we want our pain neurons away from that threshold, so we can perceive, so we can take a painful stimulus and not have an overly stimulating response, or an overly painful response.
I mean, think of, like, whether it's stressful day at work, what do people say they need to do? Like, I need to just go and reset. right? I mean,
Yeah.
and the way I look at it is like you're taking it. You walked very close to threshold. Hey, you snapped at somebody at work, or your boss snapped on you. He breached threshold.
Yeah.
It's the same thing with every neurological pathway. Is there's a natural resting state, and there's various physical, chemical, environmental, emotional things that can take that resting state and get you closer to an action, whether it's good or bad. And I think that's kind of the premise of it. So
Yeah. I mean, the beautiful thing is, like, medicine and research is starting to head in this direction. Like Andrew Huberman, researcher out of Stanford, is really good with the grounding and early morning light. We know that having early morning light, like first morning light and end of the day light, like changes our brain, changes the way it'll help reset our circadian rhythm, which plays a big role in our sleep. Which, like we talked about earlier, having good sleep cycle, falling asleep when the sun goes down and waking up when the sun comes up is a really good way of helping our body reset our brain's threshold. And having good sleep when it's the darkest, right? Like 1 o'clock in the morning, 2 o'clock in the morning, we should be in the deepest, most restful sleep, creating these neurotransmitters and internal opiates to help basically help our brain reset, so the next day we can have normal function without perceiving pain and without perceiving anxiety overly easy. Now, there's certain things that are gonna drive those pathways, but how quickly we can recover, and that's really like our practice in general, is how many of these different therapies. So it's like, yes, maybe an adjustment is good, maybe physical therapy exercises, maybe meditation, but it's how can we give you the right package.
Right. Sometimes it might be blood work and, hey, is there something inflammatory going on? Better than any physical modality that can be delivered to the patient. Like, hey, yes, you have pain, and it feels good when you get your leg or your low back rubbed on. But again, how do you make sure that that physical intervention doesn't become like an aspirin or an Tylenol, right? Yeah. If there's more to your pain, you don't want to give them something that's not really solving it. So if it's, hey, running labs, figuring like, hey, you're having this inflammatory reaction to this, let's address it. That might be, if anything, more fruitful than
if you're getting one of those physical modalities and it feels good while you're getting it done, but it don't, by the end of the day, it's like I feel the exact same pain again. It's like you have an overactive pain response. So let's do something. That, not saying that therapy is the wrong thing, because it should be part of your game plan. But maybe there is omega-3 fatty acid deficiency. 9 out of 10 people have low omega-3s.
Vitamin D deficiency.
Vitamin D. That GABA
Magnesium.
pathway is, it's a super simple thing. If you're not sleeping and you're perceiving pain and you're more an anxious person, just doing a super simple GABA receptor, like basically doing something to either increase the GABA receptor sensitivity, like passion flower extract, or just giving the person a GABA supplement and they're like, wow, I slept so good and I'm less painful and I'm less irritable, or exercise that day. It's like there's so many different things that you can use as clinical guideline or insight of what is this person's problem, so that you can use those physical modalities, use those biochemical modalities, use those neuroemotional modalities to help someone get past this pain response and get away from threshold.
So on a very superficial level, let's say sleep needs to be a must, right?
If you're a patient of mine, the first thing that I say is, how do you sleep? How do you fall asleep? How do you stay asleep? We gotta get you sleeping well. That's the first thing that I
say that too. Like there'd be people that come in like, oh, I have memory issues. Like, yeah, we want to get you sleeping well, because that's gonna be a big part. Or I have pain. Like, we got to get you sleeping. So sleep's critical.
Absolutely.
And not just sleeping at random times.
Yeah.
Like, hey,
not ambient sleep, right?
Well,
we don't want someone to be knocked out, right?
Right. Well, but then that's even though like they'll be like, well, I wake up at 5 and I go to bed at 10, but on the weekend I sleep in till 10 and go to bed at 2 a.m.
Yeah.
Again, I think that's very harmful too. Like, we need a normal circadian rhythm, especially when there's problems or trouble in paradise. We need to create some consistency in areas that we can control.
Yeah.
So sleep, motion or exercise, some type of movement, positive.
Got to move every day.
Yeah.
Every day. And here's the thing: walking, and we've said this before, walking is not exercise. Walking is so plastic in our brain. Like we
Don't
do
think
it.
about it.
We don't think about it. We don't have to focus on it. It's in, walking outside is better because at least you're getting the natural sunlight and stuff like that. But moving your body in a way that's not easy, right? Doing something like
multiple planes, right? So you have coronal and sagittal planes.
Yeah.
I think it's very critical that we get in various planes that challenge all of our receptors, because I think that's when we sit and then you go, so you're hunched down and you're moving in a certain consistent plane every single day. Hey, but don't worry, I rode the bike for 3 hours or for an hour today. Like again, you're still running in the same plane of motion, and you're not getting
thoughtless, right? Like we don't think about walking super hard. It's this is where it's like tennis or racquetball or
cognition comes into play. Like
Yeah.
you're trying to anticipate what they're going to do.
Yeah.
Right? There's a much higher order of thinking.
And even better, like I was telling someone, like I want you to do some kind of exercise, but I want you to have some kind of social aspect to it as well. Like if you could play a team sport, go join a kickball league or go join a softball team or go do, join a running club or something where you have a social aspect, because that social aspect is going to drive frontal lobe function, which inhibits pain, inhibits anxiety, and that activation, and that's literally the activation that we're talking about to get your brain out of the depressed state.
So move, sleep well, sleep consistently. I mean, we can get into diet and stuff, probably another podcast on pain.
That's so sleep and nutritional deficiencies.
Yeah, eat to a point where you know where it's coming from and you know everything on the label. If you can't pronounce it, good chance you probably shouldn't put it in your mouth. So that's very generic. But let's look at before we part for this this podcast, what labs, if somebody's got pain, like let's kind of have essential labs that will give some insight if there's inflammatory or pain mechanisms that can be brought into this. So I think I'll go through a list, and I think we construct it together so people can have this. Omega-3 ratios we talked about.
Hugely important.
Since we know arachidonic acid or omega-6, if your ratio is off and you're more favorable towards an omega-6 or inflammatory, like again, it just tells us if you get inflamed or you get there, it may be harder to modify your way out of it. So omega-3 ratios, I think
absolutely.
Your CRP, SED
CRP
rates,
is very important. Homocysteine.
Thyroid from a kind of general, again, like depression and central modifier.
I think just a standard CBC with the differential, so that way you know what your immune system is doing, but more importantly, are you anemic?
Infection. Yeah, are you anemic? So then that pulls in iron, ferritin, TIBC, iron saturation. What else have we missed? You can do an RBC magnesium.
Yeah.
Give you some insight on magnesium.
Yeah, vitamin D.
Vitamin D. You can do a methylmalonic acid to tag along with homocysteine, but gives you an idea on like B12 use.
I think
a sleep study. Oxygen, like from a lactic acid standpoint.
Not necessarily. Well, I don't want to break away from this topic because I think it's really important for people to get an idea of like what they should be asking providers to run. But from a supplementation perspective, people are always looking for a silver bullet, and I can tell you there's almost never a silver bullet. It's just the way that we were taught through medicine to like, here's a symptom, you treat it with this drug or this medication or this. Even in the functional medicine world, we still go, oh, you have anxiety, here's GABA. Well, it might not be a GABA problem.
Or maybe a GABA, it might be, or histamine. That's a lab add some histamine markers. It might be a histamine, GABA, and a dysglycemic, like blood sugar.
Blood sugar for sure. A1C is super important in this. If you have a heightened blood sugar, you're going to be more acidic and you're going to be more inflamed, and you're going to cause cardiovascular damage, which is going to signal more inflammatory process to the brain.
It just ramps the dial up.
Exactly. It's just bringing everyone closer to that threshold, and whatever we can do to drop that, either increase the threshold or decrease how close we are to threshold, I think is the key here. Now, what I was saying is, just nutritional deficiency in itself can cause these problems, because nutritional deficiency might be the reason why we don't produce enough GABA, or we don't produce, if you're vegetarian or you're vegan, you might not be getting the ingredients to make serotonin or dopamine, and I'm not calling out vegans or vegetarians, because you can have a very healthy diet being vegan or vegetarian and get all the nutrients.
It might be harder.
It's harder for sure.
Especially if you eat food-like substances. Like if you're still not eating, if you're eating in the middle of the grocery store, I think it's going to be hard to be a vegan that can get your nutrients. So you're getting very calorie-rich, nutrient-deficient foods.
I can't remember where I heard of it. It was like American vegan, or have you heard of American vegetarian, where it's like I eat crackers and chips and like no vegetables or very little vegetable content or fruits or things like that. It's like I eat crackers and hummus, and it's like, okay, but you can't eat that for every single meal, right?
Yeah.
It can't be something like such a sparse diet when it comes to nutritional density. And I always tell people when it comes to nutritional deficiency, if I tell you to make a 10-pound cake, but I only give you 5 pounds of flour, right? If you don't have the amino acids and the B, like we were talking about, B6, unbelievably common, B12, unbelievably common, folate, unbelievably common to have deficiencies in these things. So, starting with, from a nutritional deficiency standpoint, it's like if people took a multivitamin, an omega-3 fatty acid, and vitamin D, I think
just generally starting with that, I think that
generally
crush a
those
lot
three
of
things,
issues.
like we would see a drastic change, and
not ones you get at your traditional like CVS or Walmart. Again, I mean the studies
on those are really bad.
But find ones that have the right combination and doses and right forms, like not the cheap version of something. So I think those are
third-party tested. Obviously, all the supplements that we have are third-party tested. The batch number. You can go online and they'll give you the information about this batch was produced on this day. But more importantly, the third-party testing shows that it has X amount, and it can only be a standard deviation away from what they say on the bottle.
Yeah.
Versus a lot of places, like that study showing that stuff bought at
certain places. Four places that were in particular had basically wood pulp in it.
Basically wood pulp or rice bran, or like rice flour. So it didn't even have the B vitamins in it, even though it was advertised as a B vitamin supplement.
Your pee should tell you if you got B's in it.
Yeah.
So, anyways,
we could go off on this all day long.
Moral of the story from a chronic pain standpoint, it's not simple. There's some environmental things that I think everybody can look at. There's some nutritional, there's some motion, and it's never a simple answer. But there are people out there that know how to navigate this story, and it doesn't mean that medication can't be a part of it. Again, if that's a part of it, that's fine. It's just understanding why pain is there to begin with, and having a long-term strategy to address some of the plasticity that might have occurred. And then having a team to kind of help drive normal function back in. And again, like there's so much to it.
So everyone who's taking gabapentin, it's like gabapentin, all it does is it sensitizes the nerve, the receptor to bind GABA. And it's a beautiful thing. It's probably the most common medication people take for chronic pain is gabapentin. And a lot of people take seriously high doses of gabapentin.
Again, this is not our expertise. This is, we have medical providers that's what they dive into.
And that gabapentin, it works. The beautiful thing is it works, but what can we do to provide more GABA, right? What can we do to provide more of the anti-inflammatory aspect, or what can we do to help? Medication is made to be short term, right? Take care of a symptom and take care of the underlying problems that is making you have those symptoms in the first place. The problem is when we get away from that and it's just like, well, I'm not going to dive any deeper. I'm just going to have you take this medication or take this supplement even for the rest of your life. And it's like, no. The body is made to return to homeostasis. The body is made to not perceive symptoms. And symptoms are little red flags to our brain saying, this is a problem. We need to get a solution. And when we take all these steps that we're talking about, when we talk about sleep and perceiving pain is a problem, what are the other solutions, as opposed to like this little sliver of the pie, right? When you think of your treatment plan, medication should be a sliver, nutrition, supplementation, exercise, mental health. Like there's so many pieces, but if we're only taking, this one little sliver, it's like we're never going to get enough to overcome those problems.
You're leaving a lot of things on the table that can also be a part of your journey to feeling better.
Yeah, and this is why an integrative approach is so important.
So I hope everybody found this podcast helpful. If you want us to do a second version of this, we probably will at some point go deeper on the biochemistry of pain, some of the nutritional aspects behind pain. And again, this is not medical advice. This is just a discussion on kind of the textbook aspect of what makes pain happen. If you have chronic pain, if you have questions regarding it, reach out to your healthcare provider. This is not to be taken as medical advice. So can't stress that enough. Anyways, I hope everybody has a great day, and we look forward to talking to you on our next podcast.
Take care, everybody.
Have a good one.